So, Krishna sir, can we start now?
Yes, yes. I think we will start. Then we will not be able to finish on time.
Okay,
I
sir.
think you can start.
Okay, Biju can start.
Good evening, respected teachers and dear friends. I'll be starting with a long case for today. This is an 18-year-old female college student from Nagarkoil. She has presented with the chief presenting complaints of a lump in the left breast for 3 weeks duration and retraction of the left nipple of 2 weeks duration. History of presenting illness. Patient was apparently normal 3 weeks back, after which she noticed an gradually progressing lump in the left breast, which was insidious in onset, has slowly progressed to involve about 1/4 of the breast now. It is not associated with pain or bleeding from nipple or any skin changes over the lump. She also gives history of retraction of nipple of 2 weeks duration, which is a new onset retraction, and it is not associated with nipple discharge or ulceration of the nipple. She does not give any history of swelling or lump in the opposite breast or in the armpits. There's no history of pain over the swelling or cyclical variation in the nature of the lump with respect to menstrual cycles. There's no history of fever, loss of weight, loss of appetite, fatigue, or night sweats. There's no history of a recent trauma to the breast or ongoing lactation. There's no history of cough, breathlessness, bony pain, abdominal discomfort, headache, nausea, or vomiting. Past history. There's no history of lump in the breast or elsewhere in the past. No history of previous biopsies or surgeries. There's no history of exposure to therapeutic or iatrogenic radiation in the past. She's not a known case of diabetes, hypertension, tuberculosis, bronchial asthma, CAD, or seizure disorder. Personal history. She takes mixed diet. She has normal bowel and bladder habits, not an alcoholic or a tobacco user. Menstrual history. She attained early menarche at the age of 8, but she has regular cycles, 5 for 28 days. There's no history of menorrhagia or dysmenorrhea during the cycles. Treatment history. She has not taken any treatment for this lump so far except for a biopsy, and she is not on any long-term medications. Family history. She is a single child born out of non-consanguineous marriage. There's no history of in utero radiation exposure to the mother. There's no history of malignancies in the family. So coming to the summary of the history, this is an 18-year-old female student with history of early menarche, without any family history of malignancies, with no comorbidities or significant past medical history, presenting with a rapidly progressing painless left breast lump of 3 weeks duration associated with left nipple retraction.
So, Biju,
Sir?
so this is a patient from Nagarkoil.
Yes,
right?
sir. Yes, sir.
Okay. So you said she has attained early menarche. So what is the definition? At least there is an arbitrary definition of early menarche, and what is the definition of late menopause? Because these two are risk factors for breast cancer.
So early menarche is less than 10 years of age, and late menarche is more than 15 years of age.
No. Early menarche and late menopause.
Late menopause is more than 60 years of age.
Are you sure? Just go and verify. Okay,
sir.
so you feel that this patient is having an. So when did she attain her periods?
During her 10 years of age, 8 years of age.
8 years of age. So that is a little early for the
Yes.
girls. So most of the trend is most of the females are nowadays, because of the dietary style and lifestyle modifications and factors, are attaining menarche before 10 years of age. But technically, as per definition, this becomes an early menarche, accepted. So what prompts you? Suppose this patient, you have not examined the patient, is an 18-year-old girl with a rapidly growing left side breast lump.
Yes,
So
sir.
what are the differential diagnoses that comes to your mind at the end of history?
Sir, as per history, because she is too young, my first possible differential diagnosis will be benign lesions followed by the malignant lesions. So with history, it can be either in fibroadenosis or a fibroadenoma, or it can be even a breast abscess or a breast cyst, or it can be some interrectal papilloma or ductectasia or some
Do
fat
you think
necrosis.
that all these things will grow in about 3-4 weeks duration? Fibroadenoma, does it grow in 4 weeks?
No, sir. All these things are slowly growing lesions, but because age is too early for a malignant process, with just history, I think benign lesion should be the first possible differential diagnosis. Though nipple retraction and this rapid growth is uncommon with benign lesions.
Okay, what are the benign conditions in children or teenagers, or even you can say young women up to 25 years of age? They are benign lesions but still can continue to grow. See, we know that growth itself tells it's malignant, but
Yes,
there
sir.
are some benign lesions in the breast
Yes,
which
sir.
actually can start growing. They may be either benign or they may be borderline lesions. So, can you give some example of breast lesions in children or young women which can actually keep growing and mimic malignancy?
So fibroadenoma can grow with age and then regress after menopause.
But which fibroadenoma grows so fast? What are the other conditions other than the fibroadenoma in young women which may mimic malignancy?
Benign phylloids.
Do you have something called malignant phylloids and benign phylloids? Is that term still in use?
No, sir.
Go ahead. So, can you name some other lesions which are coming to your mind, considering that this girl is a young girl?
Fibroadenosis, or I mean, the benign lesions, sir. You're asking about the benign lesions?
Benign lesions which can mimic.
Can be breast abscess or fat necrosis.
So, you remember there are few conditions which are actually benign but can present as if they are malignant. One is, it's a well known condition called juvenile fibroadenoma. These juvenile fibroadenoma can actually rapidly grow. In fact, it can even grow within about a few weeks and can very much mimic malignancy. So keep juvenile fibroadenoma. Juvenile papillomatosis. This is again a benign condition. It can present like a rubbery lump in the breast. Hamartomas. Hamartomas many times are present from the time of birth. You should keep that in mind. You should also keep, there is a condition called PASH. Basically, it is an angiomatous stromal hyperplasia, and this can actually imitate breast cancer. So when you have a young patient, still you are right. You have to think of benign, which is mimicking malignant. Borderline conditions which can behave benign or can become malignant, phylloids tumor.
Okay, sir. Can I proceed?
Sir, can I add?
Yes, please proceed.
Yeah.
Mr. Umar, sir.
No.
Sir, can I add some points?
Yeah, you can.
This 18 years old girl, don't think about only mass arising from the breast. Can also think of other possibilities like lymphomas. Breast lymphomas can one of the possibilities, and rhabdomyosarcomas. So also one of the possibilities. The rapidly growing tumor only occurring in the breast also.
Okay.
So, Biju, I was about to ask you that. So, you told that this is localized to the breast. So, what are the other malignancies? Because now let us say that it is malignant. What are the malignancies in the teenage girl which can present as a breast mass?
So at this age, lymphomas can present, especially non-Hodgkin's lymphomas. Sarcomas can present either rhabdomyosarcoma or phylloids tumors. The carcinomas can also present, but it is rare at this age. And very rarely metastasis to breast can happen.
Correct. So, putting all these things, which do you think you'll put up in the card? A young girl, 18 years, other than, do you think infiltrating ductal carcinoma breast CA is more common? You have given a couple of benign conditions, but now you're told malignant. Which one in the malignant do you think you'll put it up in the card?
So because the patient is not having any other constitutional symptoms and it is a rapidly growing lesion with nipple retraction, I will put carcinoma as the first possibility, followed by lymphomas and sarcomas.
Okay, so at the end of history, can you tell me what are going to be your possible differential diagnosis in order of occurrence?
So first, I would think about fibroadenoma or fibroadenosis. Second, I'll think of some granulomatous disease of the breast.
Are you going to think of fibroadenosis in an 18-year-old girl or fibroadenoma?
Fibroadenoma, sir.
Fibroadenosis starts more towards the middle age. It's like the ANDI, the abnormal, development and involution of breast. It comes in the spectrum of disorders after a couple of cycles and then years of cycles of menstruation where the breast can have nodularity. So fibroadenoma, juvenile fibroadenoma, giant fibroadenoma, these kind of conditions are what you'll have to keep in your mind. Let's go to malignant. In the malignant, which are the ones you are going to place higher in the card, what do you call these cancers as? See, it's an 18-year-old girl with cancer. So what group do they fall under in today's definition of cancers?
Adolescents and young adults.
Can you define AYA cancer?
Sir, they are the cancers which occurs in the age group between 12 to 18 years of age.
AYA means 12 to 18. Are you sure? Is AYA definition 12 to 18?
I'm not sure about it, sir.
Please go back and read what is AYA definition, because today you are having a lot of patients who are having separate guidelines for AYA cancer, starting from psychological screening to management, right? So AYA once you say AYA, you have a different epidemiology of cancer that occurs. What is the incidence of breast cancer in India, or how common is breast cancer, and what is the incidence of breast cancer in Tamil Nadu?
Sir, the incidence of breast cancer in India is about 27% among all the cancers.
Do you call it 27%, or do you call it how do you describe the incidence?
27 per
Tamil Nadu Cancer Registry. Where is the Tamil Nadu Cancer Registry, Biju?
Sir, it is in Adayar.
So Chennai, right?
Chennai. Yeah.
So you have a MMTR, which is mainly for the Madras Metropolitan Tumor Registry, but that also holds the data for the entire state, right? So
Yes.
according to Tamil Nadu Cancer Registry, can you tell me what is the epidemiology of cancer? Which are the common cancers which are seen? Can you name the top 5 cancers in women in Tamil Nadu?
First is the breast cancer, followed by cervical cancer. And third is the lung cancer.
No. Lung is the most common in the world across all age groups. Oral cavity, oropharynx, and cervix. And stomach. Okay. These are the top 5 cancers among women. So now, breast cancer is still common, but this comes under the AYA group. In AYA, you would like to, as Dr. Satya mentioned, you will have to keep conditions like sarcomas, could be RMS or NRMS, could be lymphomas of the breast. Which lymphomas usually affect the breast?
Non-Hodgkin's lymphoma, sir, DLBCL.
Then, other than DLBCL, what are the other lymphomas that can affect the breast? Especially children or very young AYA adults. What types of non-Hodgkin lymphoma? DLBCL is one, you are right. What else? You may have to keep all these things, broad differential diagnosis in your mind. You can't pin down to one diagnosis because you have a very atypical case. You have an 18-year-old girl with a breast mass. So you'll have to keep lymphoproliferative disorders also in your mind. Normally, Burkitt lymphoma, lymphoblastic lymphoma, DLBCL, these are the common lymphomas that will affect de novo breast. And of course, there is somebody in the chat who has tried mentioning ALCL. ALCL is for the ones which are more implant associated lymphoma. That doesn't come in the de novo breast. Okay, that's for somebody who has typed ALCL. So these are the DDs you have to keep in mind. So you keep sarcomas, lymphomas in the mind at this stage. Don't pin down to ductal carcinoma or breast carcinoma. Okay, please proceed.
So on general examination, ECOG performance status 1, there's no pallor, cyanosis, clubbing, pidal edema, generalized lymphadenopathy. There's no neurocutaneous markers. Height is 150 centimeter, weight 52 kg, BMI is 23 and BSA 1.46. Systemic examination, cardiovascular system within normal limits. Respiratory system, bilateral lung fields are clear. Periabdomen is soft, no organomegaly, no pelvic mass, and no free fluid. Central nervous system within normal limits, no spinal tenderness. On local examination, inspection, the left breast is marginally larger than the right. There's no obvious lump visible. Left nipple at higher level than the right. Left nipple is retracted. Skin over the breast is normal. There is no ulcers, skin edema, scar, or sinuses. Both the breasts falls forward equally, and there is no visible axillary, supraclavicular, or cervical swelling. On palpation of the right breast, it is not warm or tender. Normal fibroglandular pattern is palpable. No lump palpable. Nipple area complex is normal. The left breast, not warm or tender. A firm to hard lump of 6 into 5 centimeter, palpable in the left upper outer quadrant. Medially, the lesion is 1 centimeter lateral to the nipple area complex. It is not involving the axillary tail. The margins are ill-defined. It has a nodular surface, non-fluctuant. It moves with the breast tissue and not fixed to skin or pectoralis muscle. The left nipple is retracted. There is no lump underlying nipple area complex, and there is no discharge per nipple. Examination of the axilla. There is a 2 cross 1 centimeter mobile left central axillary lymph node palpable. No other lymph nodes in the right axilla, bilateral infraclavicular or supraclavicular region. PV and PR is within normal limits. So the summary of the case, 18-year-old female with early onset menarche and no family or medical history, presenting with rapidly progressing left breast lump with nipple retraction of 3 weeks duration. On examination, found to have a 6 cross 5 centimeter lump in the left breast upper outer quadrant. The lump has an ill-defined borders and irregular surface, moves with the breast tissue and not fixed to skin or underlying muscle. Nipple area complex is normal, has an associated mobile 2 into 1 centimeter left axillary lymph node.
So this patient have you improved anywhere from your previous differential diagnosis? Could this be a systemic lymphoma involving the breast? Is that a possibility with this kind of presentation?
So with history and clinical finding, it may not be the first possibility because patient in history, patient does not have
Can
any
it still be a primary breast lymphoma?
So the feel of the swelling is more firm to hard, and the node is also hard. So it still can be a lymphoma, but more favoring a carcinoma because of the feel of the swelling.
Are you ruling out rhabdomyosarcoma after clinical examination?
Yes, sir, because the surface is nodular and highly irregular, and there is the lesion is actually fixed to the breast tissue, and there is an axillary node also. So I'll keep rhabdomyosarcoma next to the carcinoma.
So which are the sarcomas which normally have nodal spread?
Synovial sarcoma, clear cell sarcoma, alveolar rhabdomyosarcoma, epithelioid sarcomas. These are the sarcomas which has spread to the lymph nodes.
Recording in progress.
So you know that RMS can spread to the node. So having an axillary node doesn't mean that it cannot be RMS. And you know that our node also has to be removed and for your proper staging and grouping. So some irregular borders or firm to hard consistency does not rule out sarcoma yet.
Yes.
Maybe a systemic lymphoma, I accept you can rule out, but still you don't know, is it a primary lymphoma of the breast involving the lymph node? Is it a rhabdomyosarcoma of the breast involving the lymph node? Or is it that rare carcinoma involving the lymph node? So you still, after examination, you've not reached much anywhere further. And at 18 years of age, I think still you will have to keep these differentials higher on the cards and then keep your carcinoma breast lower on the cards. Okay, I think that is you may have to go by the epidemiology of the tumor. So in India, at what is the average age of breast cancer compared to the breast cancer from the rest of the world? In India, do you have a higher incidence of AYA breast cancer compared to rest of the world? How is the epidemiology of Indian breast cancer different from the rest of the world?
Occurs in more older age group than the rest of the world.
Really? You're telling me opposite. See, I'm not asking you the epidemiology just to pull your legs or make you read epidemiology and statistics. Because when you are going to write your differential diagnosis, you should put it in perspective of from where the patient is coming and what are the DDs based on the epidemiology and the incidence of cancer in that particular region. So you are talking about India, you're talking about the southernmost part of India, and you will have to, that breast cancer is not very common. So in India, normally they say the breast cancer average age is about a decade lesser than the developed world. And the developed world sees higher incidence of hormone positive breast cancer, but India sees a higher incidence of triple negative breast cancer. The presentation is more early stage in the Western, presentation is more aggressive and locally advanced stage in the Indian population. These are the smaller multicentric studies which have shown this kind of a pattern, and it is across all registries. Therefore, it is not that breast cancer cannot occur in young women, but it cannot occur in this young woman. So that is why I'm telling you, don't keep breast cancer higher up on the cards. You can still keep a primary lymphoma of the breast, which can be the most common, depending on whether it is sarcoma or lymphoma. Lymphoma is more common. Overall, amongst all sarcomas, which are the commonest pediatric sarcomas? You have different types of sarcomas. You have NRMS, RMS, so many types. There are about 10 to 15 types of sarcomas. In pediatrics, which is the most common sarcoma?
It's embryonal followed by alveolar.
So basically RMS, right?
Yes. Yes,
So RMS is the most common spindle cell tumor in the pediatric population. By the way, what is your definition of a pediatric population from oncology perspective? You said AYA is actually, your definition was wrong. It is age of patients between 50 up to 40 years. That's basically 39 years. Okay. So in this group, adolescent and young adult, where do you put the pediatric population? Because pediatric population are the ones who are going to have their own protocols, right? So how will you define pediatric oncology for your practical purpose in selecting protocols? Now, if this patient comes out as a NHL aggressive of the breast, what protocol are you going to use for this? It's a B cell, high grade B cell lymphoma of the left breast with axillary node involvement. So what protocol do you think you will use for this patient?
Use as that of an adult protocol only, 20 years of age.
She 18 or 20? This girl?
Yes.
18, I thought, no? I heard as 18. Let us say, okay, let us say she is 18 years. Viju, let us say she is 18 years.
Okay.
No problem. If she is 18 years, what protocol are you going to use for her?
Chemotherapy protocol, sir.
I know it's chemotherapy. Will you use pediatric or will you use adult?
Pediatric.
Up to which age will you be using pediatric protocols? And are there any studies to say that, so if this is a high-grade B-cell lymphoma of the left breast, Dr. Biju,
Yes, sir.
tell me what is the protocol you're going to use for this patient? You've done a biopsy, it has come as high-grade B-cell lymphoma, and translocation for Burkitt is negative, but still is a high-grade B-cell lymphoma of the left breast. What would you like to use for this patient?
Try to use R-CHOP with IT methotrexate.
Yeah, so this is kind of an adult protocol, but if you go to the West and if you look across the literature, up to 18 years of age, and some literature say even up to 25 years of the age, okay, it is called as pediatric, then you have some group called as adolescent oncology, and then up to 25 years of age, people tend to select pediatric protocols over adult protocols because the outcomes are better. So there is data, please go back and read. You will be selecting protocols like LMB, and sometimes at least you will select protocols like EPOC and infusional regimens because these tend to do much better for this age group and not the adult protocols like R-CHOP. Okay, so now I'm coming, so that is why I'm trying to say if it is an 18-year-old girl, still look at them like pediatric population while giving a DD in your exam. Okay. Fine. So at the end of your clinical examination, you have a left breast tumor. And let us assume now I come back to your differential diagnosis. If it is going to be not a lymphoma, it is not a sarcoma, and you still think it's a CA breast, what is the stage?
So with the clinical tumor size, it is T3N1. It is 6 cross 5 centimeter and a mobile axillary node.
In this kind of a case, in your final diagnosis, what else should you mention? Have you mentioned about family history?
Yes, sir. There's no family history.
Yeah. So what family history did you ask? Who all did you screen for family history?
First, second, and third degree relatives for especially cancers of breast, ovary, prostate, and pancreas.
Breast, ovary, prostate, and pancreas. Okay. Can you define who is first degree relative?
First degree relative will be the mother and the brothers and sisters.
And one more.
And
who are the ones who are directly related to you by blood?
And their
immediate relatives.
Father, mother, and their siblings and their kids.
So it is the children, the siblings, parents. These are the ones who are genetically directly connected. No, they are the first degree. Who is second degree relative?
It will be their parents, brothers, and sisters.
So basically, the aunts and uncles and their children, right?
Yes.
The blood relatives and the genetically related people of your parents become the second degree relative. So what's their history of, okay, so you said there is no family history. So what are you looking for? Which syndrome do you think you want to screen this girl for, 18-year-old girl? If it happened to be a breast tumor, and I will go with you, you are thinking of breast cancer, what are all the familial syndromes associated with breast cancer?
Sir, we would like to screen especially for hereditary breast and ovarian cancer syndrome.
Agreed. That you already told me. So you said breast, ovary, you said prostate in male, accepted. What else?
The Lee-Fraumeni syndrome.
What are the tumors associated with Lee-Fraumeni syndrome?
Sir, it is breast, lymphomas, prostate cancer, and
no. When it comes hereditary, what are the most common, especially that can run in the family? Always remember the mnemonic B. Blood, brain, bone.
Okay.
So blood related will be lymphoma, leukemias, brain tumors, bone tumors. Okay?
Okay, sir.
And breast.
Okay.
Okay? Blood, brain, bone, breast. All these can be Lee-Fraumeni associated. What are the other familial syndromes which can come with breast cancer?
We can have CDH mutation, which cause low blood breast cancer and gastric cancers.
So what is that syndrome called? Is it CDH or some other syndrome which is associated with breast? CDH is more of hereditary diffuse cancer, but what about the other familial syndromes?
Peutz-Jeghers syndromes.
Peutz-Jeghers down in the list. What else? Can there be another gene, P10 mutation?
Yes, sir. P10 mutation. Cowden syndrome.
What is a P10 mutation? What is that syndrome called?
Cowden syndrome.
So basically, you ask for history related to BRCA1, BRCA2, Lee-Fraumeni, which is P53, Cowden syndrome. These are the most common. Of course, the other ones like ATM and Peutz-Jeghers, they all come, but they come a little bit down in the list. Okay. So all these cancers you have to ask. So have you screened for all this in this child? In this small girl, in a young girl?
I have asked for history, sir. History-wise, there is no history of malignancies.
So there is no history of malignancy. So you are not associating any hereditary cancer for this girl, right? So what do you want to do with this patient? You ask for the test and let us see how do you want to evaluate this patient?
So first, I'd like to confirm a critical findings with an ultrasound breast and axilla to characterize the lesion, and also to guide a biopsy from the true-cut biopsy from the lesion.
Are you going to put it up here on the screen, or do you want me to give you the findings?
So this patient had undergone an ultrasound of the breast. Sir, is the screen visible?
Screen is not visible. Okay,
Not
forget,
visible.
no problem. I will tell you the ultrasound finding. There is a large irregular lobular mass with variegated mass which is seen in the left breast between the 1 o'clock and 5 o'clock position, measuring 6 into 5 centimeters with mild increased vascularity. And in the left axilla, there are two nodes which are 1.5 into 1 centimeter and one more node which is a 2 into 1 centimeter, both in the axilla with the distorted hilum.
Okay, sir.
That's the finding. So what is so how is it going to take you further towards diagnosis? What do you want next?
Get a histological confirmation with a true cut biopsy from a bone needle biopsy from the primary lesion and an FNAC from
Okay,
the
Biju. So what was our first differential diagnosis when it comes to a adolescent young patient with any kind of a lump? What did I tell you which will be the safest bet in the exam?
lymphomas.
So lymphoproliferative disorder. So whenever you're looking at lymphoproliferative disorder, before touching the breast, what all do you want? Don't you want a CBC?
Basic
What if
investigations.
this patient is a disseminated, she's got a Burkitt lymphoma with involvement of the extensive involvement of the marrow with very low platelet count. You don't know, right?
Okay.
So always when you start with the CBC, okay? And then when you have a lymphoproliferative disorder, along with the CBC, what is the reflex test that you will always ask when you're suspecting a lymphoproliferative disorder?
Yes, sir.
The
And
patient is a
LDH.
casualty. Sorry?
Yes, sir. LDH and electrolytes.
Why do you want LDH and why do you want electrolytes and why do you want ESR? What is ESR going to contribute?
So this gives an idea about the burden of the disease. Both the
So what
LDH
would
and
happen?
ESR. And this also tells about whether the patient is in any spontaneous tumor lysis. So we need to check about.
Very good. So for tumor lysis, what are the other parameters you would like to ask of as a reflex? What is the tumor lysis panel that you would like to ask? I said CBC. So CBC, you are mainly looking at the platelet and white cell count and whether there are any abnormal differential count, whether you have any blasts or abnormal cells. That's your interest. So I'm telling you it is normal. LDH is about 280. It is normal. What are the other tumor lysis parameters you would like to ask for when the patient is lying in the casualty?
Uric acid,
Very good.
potassium, phosphorus.
So how do you define tumor lysis?
So we have both biochemical parameters, laboratory parameters and clinical parameters.
What is that criteria called?
It's called Bishop's criteria.
Good. So I will tell you that all was normal. Okay. And then what do you do in your hospital? See, always you stick to whatever you're doing in your OP, you tell in the exam. You need not think out of the box. So if this patient is coming to your OP, before sending to true cut biopsy, what are the other tests that you will do before sending it to the surgeon?
The basic investigations including CBC, renal function test, liver function test, and the bleeding profile, bleeding time, clotting time, and the viral markers.
Yeah, so please say that I would like to ask for the counts and then I will also like to look for the coagulation parameters. Okay. And after that, I will send and you will look for the viral markers, everything you look, no?
Yes.
And then you will send it for true cut biopsy. Now, what is the importance of viral markers in this patient?
One thing is because patient is going to go for invasive procedure for to know the mark status.
Accepted. In your patient, you are thinking of a lymphoproliferative disorder with the best mass. What is which viral infection are you wanting to rule
out? Both HIV and HCV.
Why HIV in this patient?
Because HIV brings in an immunocompromised state where other viral associated lymphomas can happen.
That's okay. That is viral associated infection. But what is atypical in this patient which probably can fit in with HIV? In HIV, you can have extranodal lymphomas, much more common than nodal lymphomas at atypical sites, right? So immunocompromised patients can have these kind of extranodal presentations of aggressive lymphomas. So once again, you will have to look for retroviral disease. Okay. So there are a lot of points. So whatever you do in your routine, you can mention, I will look for a CBC, I will look for tumor lysis. If all are normal, I will go in, I will also parallelly screen for the routine biochemical profile, including viral markers, look for BT, CT and coagulation profile. If everything is normal, I'm going to go for a true cut biopsy. I think this answer in a flow will give you the safest zone in the exam. Okay. So what was a true cut biopsy? So you sent this patient, you want a true cut or you want an FNAC?
I want a true cut biopsy from the primary lesion and FNAC from the node.
True cut from the primary and FNAC from the node. Accepted, but I need a reason for both. Why do you want both?
Biopsy is because we got too many differential diagnoses. We need a good chunk of tissue to come to a conclusion for IHC studies.
Very
either
good.
Carcinoma or lymphoma. And
Okay.
FNAC from the node may impact the management if it is in carcinoma of the breast.
Okay. So what was a true cut biopsy? And why do you want an FNAC from the node?
So because the clinical picture was more fitting into carcinoma, I would like to confirm the nodal, the patient has already done a biopsy. I just want to rule out whether that node is because of inflammation or because of malignancy. Because it will change.
Okay, if your tumor came as a spindle cell tumor and suspicious of RMS, would you still go for a nodal FNAC? You have, let us say, a 1 centimeter node in the axilla. If the same patient became an RMS, do you think addressing the node will be as important as you would have done in a case of breast cancer?
It won't change the management, sir. Anyhow, we'll do a lymph node dissection along with the resection of the primary.
You will anyway do an excision. Okay, so if it is a large, huge tumor in the breast with a small lymph node in the axilla, and if it comes out as RMS after all immunohistochemistry, will you be going still for a mutilating surgery?
No, sir. We'll start with chemotherapy.
Okay. So when it comes to RMS also, addressing the node actually is important because it is important for staging and prognostication. Okay. So trying to do an FNAC from the node is not wrong, even if it comes out as sarcoma. If it was a non-RMS sarcoma, and then you have a node involvement in the axilla, what is the stage of disease? What was the stage in the previous staging and what is it in the revised staging? You didn't come prepared to answer these questions. No, you were more focused on breast cancer. This is what will happen in the exam. Okay, so you'll be mentally prepared and everything will be ready for breast cancer, but the whole discussion will go on sarcoma and then you should not fall in the trap. Okay, so just keep your mind very open to answer anything. So you will when you have a pediatric, 18 is still pediatrics. So when you have a pediatric patient with some solid tumor, you have to actually look at many things. In general examination, you have to look at the habitus. You have to look for dysmorphic features. You should ask for history of congenital abnormalities. You should ask whether the child was low birth weight, whether the patient was a cesarean section or a normal delivery. All these histories are missing from your case history because 18 years is still pediatrics. Okay. So pediatrics history taking is very, very different from adult. And many of the sarcomas are associated with hemihypertrophy, Beckwith-Peatman, and there are so many tumors associated with low birth weight. So you should be able to go back and elicit this history. If you are not able to, at least you should try to say that I have asked for all this history. So please note it down. And this is for all the YMO students who are here today. When there is a patient up to 18, 20 years of age, they are like pediatric patients. You have to ask all these histories in your history taking. Okay. So coming back to your case, Biju, please tell me what was a true cut biopsy.
So the true cut biopsy was
imaging, or you would do it after the true cut biopsy is ready.
Sir, sorry, sir, I didn't get your question.
Would you want any other imaging, or are you happy with the true cut biopsy alone?
Sir, I would like to have an MRI of bilateral breast, but I would like to do it after the biopsy because I want to.
What was your biopsy report?
It was infiltrating ductal carcinoma, grade 2, ERPR negative, HER2 positive.
ERPR negative and HER2 positive.
Yes.
Okay. So what is definition of ER positivity, Biju? When do they call a patient ER positive?
So if there is a nuclear staining of 1 to 100%, it is called as ER positivity. 1 to 10%.
Less than 1% is negative. Whereas if it is 1% and more, it becomes positive. So is there any scoring for ER positivity?
ALRED scoring is there.
Very good. So what is the maximum score in ALRED?
8.
Very good. How do you define HER2 positivity?
So to positivity, we do an immunohistochemistry staining for the cytoplasm first.
Accepted.
And,
So what is the percentage cutoff for calling HER2 positive?
It is 10%.
And how is that 10%? So 1 plus 2 plus 3 plus all are 10%? Or is it 10%, 20%, 30% like that? Based on that, they will tell.
It is based both upon the intensity of staining as well as the amount of cells which are stained. It should be a complete membrane
intensity as well as amount which are stained. So what is 3 plus what percentage cells should be positive, and in 1 plus what percentage should be positive?
If there is complete membrane staining of more than 10% of the cell, it is 3 plus.
So it is basically anything more than 10% is HER2 positive. Depending on the completeness of the membrane staining, if it is mild, moderate, or intense staining, you call it 1 plus, 2 plus, and 3 plus, correct?
Yes, sir.
Is that what you're trying to tell me? Because that's what I'm able to understand. How do you define HER2 positivity?
So it is based upon the completeness of cytoplasmic membrane staining.
Accepted. So if there is any doubt and inter-observer variation, what test would you want to do?
To confirm with the FISH testing.
So what is FISH?
So it is an in situ hybridization technique where we are using probes to detect the presence of that HER2 gene in the DNA. And depending upon the number of copies with respect to the centromere enumeration probe, we define whether it is FISH positive or negative.
So what are the two probes and what are the signals that you are picking up in FISH?
We are having probes for both the HER2 probe as well as the CEP17 probe.
So what is a CEP17 picking up in FISH?
So it is the centromere probe of the chromosome number 17. We see the number of HER2 copies with respect to that enumeration probe ratio.
So beyond what, if it is there, you are going to call it positive?
There should be.
So the number of signals which are picking up the HER2 over the number of signals picking up the CEP probe on chromosome 17, that ratio should be more than
2, or the number of copies should be more than 4 or equal to 4.
So this patient is directly a HER2 3 plus?
Yes, sir, by IHC.
Okay. So now what else test you want to do for this patient?
Other investigations, I will need an MRI mammogram of both the breast because this is an young patient and the patient may need a breast conservation surgery. I just want to rule out multicentricity and bilaterality. And I'll also want to do an metastatic workup with the CT chest, abdomen, and pelvis. And,
so this is a patient with T3N1 clinical staging.
T3. Yes, sir.
Okay, so you are thinking of, okay, so did MRI pick up any multicentric tumor or any other? What are the relative and absolute contraindications for breast conserving surgery?
Sir, the absolute contraindication is persistent positive margins, first trimester pregnancy where we cannot give radiation therapy within the next 16 weeks, and multicentricity, and patients who has already received mediastinal radiation for a lymphoma, and
so did your patient have any of these findings?
Sir, actually the patient was not able to afford MRI, so we haven't done an MRI.
So you wanted an MRI. Okay, yes. So you have done a routine bilateral mammogram?
No, sir, only ultrasound breast was done. Patient was too young to do a mammogram.
Okay, so now what do you want to do for this patient?
And I want to do an staging workup with the CT chest, abdomen, and pelvis.
Okay.
And then an echo ECG and an echocardiogram to assess the baseline cardiac status.
So what about bone scan?
Sir, if there is any equivocal finding in the CT scan, or if there is an increase in ALP in the blood profile, I'll go ahead with the bone scan.
Patient okay, so that's a protocol you are following. So that is the protocol you are following?
Yes, sir.
Fair enough. So if you are following that in your institute, you can confidently tell me. But let us say you are not in a resource constrained setting and you are going by the guidelines. What is the indication for PET-CT in breast cancer?
So stage 3 and above, we can use PET-CT as a metastatic workup.
What is your clinical stage in your patient?
Stage 3A.
Yours is stage 3A.
Yes.
What is the indication of PET-CT as per guidelines in early breast cancer?
In early breast cancer, only for CT scan is giving some equivocal findings. We can
It is not showing any equivocal finding. It is stage 2A. But I feel I need a PET scan. So am I going with the guideline or am I going against the guideline?
It's acceptable to do PET scan as a metastatic workup. If we,
yeah, I know you will accept me because I'm your examiner today. But what is your call on whether PET scan can be done or not?
Clinically, if we feel that the malignancy is aggressive, we can do a PET scan to assess a metastatic workup.
So patients with aggressive biology like triple negative or HER2 positive, even in early stage breast cancer, you can go for a PET scan. That's a guideline. So that's given as an option investigation. So when you see everywhere, even in the exam, this is one problem I'm seeing. When you say PET scan, sometimes there is a discordance with the examiner. They say that you want PET scan for everybody, is it already there and all that. Sometimes when you don't say PET scan and when you only say CT chest with abdomen screening, again, you land up in problems. So first tell what you do in your center. It is very acceptable. In our institute, this is what we are doing. We could probably do these things. So this could be a very, the easy way to take up the, the discussion further. So after all investigations, what is the stage of investigation? What is the stage of cancer for your patient?
So this patient this patient actually underwent a PET-CT scan, and the primary tumor size was only 3.2 into 2.8 centimeter with an SUV of 4.8, and the node was 1.5 cross 1 centimeter with SUV of 2.8. So after the investigation, though there is a discordance between the tumor size clinically and PET-wise, it will be T2N1.
It is T2. What was the size? I'm sorry.
Sir, both with ultrasound and with PET-CT scan, the size was 3.5 cross 2.8 centimeter.
So it's a very small lesion, 3.5 cross 2.8 in the ultrasound as well as on PET scan. So it's a clinical T2N1.
Yes, sir.
Can you define N1, N2, and N3 clinical?
So clinically,
N1 breast cancer.
Mobile axillary nodes, N1. N2A is matted or fixed axillary node. N2B is internal mammary node in the absence of axillary node. N3A is infraclavicular. N3B is both internal mammary and axillary. And N3C is supraclavicular node.
Very good. So now based on these findings, what is going to be the plan of action for your patient?
Sir, this patient, I'll discuss with the patient regarding her further treatment plan, and I will try to give her neoadjuvant therapy to downstage the tumor so that I can enable breast conservation surgery comfortably for this patient, followed by radiation therapy to the remaining breast, followed by the adjuvant systemic treatment. So
the patient is asking for breast conservation surgery, or have you voluntarily offered it for her?
No, sir. The patient has demanded breast conservation surgery. Currently, patient's breast is of medium size. So it's kind of a large tumor in a small breast with clinical finding. So she needs tumor downstaging. As well as because the patient's node positive, neoadjuvant chemotherapy would be preferred for this patient.
So what chemotherapy you want to select for your patient?
Sir, I would give chemotherapy with a dual anti-HER2 therapy because she's in stage 3 disease. I'd give her docetaxel with carboplatin along with trastuzumab and pertuzumab for 6 cycles with a neoadjuvant setting, followed by surgery and RT, followed by further anti-HER2 therapy depending upon her pathological.
I'm sorry, I lost your signal. What was the neoadjuvant you wanted? Sorry.
Sir, I'll give a taxane and platinum-based neoadjuvant chemotherapy along with a dual anti-HER2 therapy.
Okay, so what is the advantage of adding dual anti-HER2 therapy to neoadjuvant, and what is the data for it, and what extra percentage of benefit you're going to give the patient?
So in neoadjuvant setting, adding dual anti-heterotherapy has increased the pathological complete response rate. The maximum PCR which you have seen is around 68% in the TRINE2 trial. And since the pathological complete response rate is a surrogate marker of survival, I have tried to increase the PCR with dual anti-heterotherapy.
So if 100 people you treat with dual HER2 blockade, compared to somebody who has not received dual and only single trastuzumab blockade, what percentage will upstage into pathological CR by giving dual HER2?
So among the trials we have, the maximum PCR we have seen is 68%.
So there is a rough 10 to 12% increase in the PAT-CR by adding dual HER2. So especially in patients who are wanting breast conservation, aggressive tumors, you are justified in adding trastuzumab with pertuzumab. So how many cycles do you want to give this patient and then reassess?
I'll reassess clinically every cycle, but maximum I'll give 6 cycles of chemotherapy with anti-heterotherapy. Then subject the patient for surgery.
Okay, 6 cycles you gave. Clinically, the mass is not felt. You incidentally got a radiological imaging also done, and there is no mass that is felt. So how are you going to remove where are you going to go and remove the breast tumor now?
So prior to breast conservation therapy, we should have marked the primary tumor site as well as a node with a marker, so that
you have to clip. So that is what I was about to tell you. So you have to clip the primary tumor, and you should also, using fiducial markers, you should mark the axillary node. Okay, a node which is FNAC positive, post neoadjuvant, if it has become FNAC negative, there is even a chance that you can give sentinel lymph node just for that tumor after tumor excision. Okay, otherwise you can do a limited axillary dissection, but you have to mark with fiducial markers. So don't forget, whenever you are going to take a patient for neoadjuvant chemotherapy, don't fall in the trap. Don't forget to mark. Okay, so that's why I asked you that question. So let us say that this patient has achieved PAT-CR. Okay, in both the breast and the axilla. What's your plan now for this patient?
We continue trastuzumab and pertuzumab alone for a total period of 1 year. And then this
patient was almost CR with 5% residual tumor. What is your plan?
If she has not achieved PCR, there's an option to change her anti-HER2 therapy to trastuzumab emtansine for 14 cycles. How many cycles? 14 cycles.
Based on what data?
That is based on the Catherine study.
Okay. So she comes back to you and says, sir, doctor, I'm very poor. I'm not able to really afford the trastuzumab-pertuzumab combination. Why don't you give me only trastuzumab? Will you be justified, or will you push her for trastuzumab-pertuzumab?
So we can continue trastuzumab alone for a period of 1 year.
Are you justified in doing that? She's a PAT-CR. She has responded excellently well to dual HER2 blockade. Do you want to de-escalate to only trastuzumab at this level? What does the guideline say?
If she cannot afford dual anti-heterotherapy, we can continue trastuzumab alone.
Okay, now I say she can afford. The choice is left to you. Do you want to continue both, or is it okay to only give single agent trastuzumab?
I'll continue both, sir, because she was not positive initially.
Correct. So she is a locally advanced tumor, but the guidelines say there is an option to skip dual HER2 blockade in PCR patients. Okay. Otherwise, and since she was node positive upfront, you have to give dual HER2 blockade. But if at all there is a situation where you are forced to drop, you can do it in those patients who have completely achieved a pathological response. Okay. If they don't, there is no option. The best one is to give TDM1 into 14 cycles. So you completed therapy, and you gave radiotherapy, and you completed 1 year of dual HER2 blockade. Now what?
She will be kept on regular follow-up every 3 months with clinical examination, and with mammogram done 6 months after radiation therapy and yearly once.
So how do you follow up this patient? How do you want to follow up this patient?
Sir, this patient for the first 2 years, she will be the clinical examination will be done every 3 months, and then 6 months up to 5 years of age. And for evaluation of the remaining breast and the opposite breast, because she is young age, I would advise MR mammogram yearly once until she reaches 30 years of age. And from 30
is that a guideline? She has come to you You are very happy. At third year follow-up, you're telling her, Madam, you have got cured. But still she is sitting with tears in her eyes, and you ask her, what's the problem? She says, I'm completely amenorrheic.
So
I'm not having any menstrual cycles, and I'm worried about marriage.
So ideally, this patient we should have started on ovarian function suppression prior to starting chemotherapy, or we should have given the option of oocyte preservation prior to starting chemotherapy. And in which case,
exam, you will not have a chance to come back and give these options after 6 months, no? So when you have a very young patient, Biju, please don't forget. So when you have a young patient, please consider fertility preservation. Onco fertility preservation has now become a hot topic, and it is a very important topic. So a young girl, you either go for ovarian preservation using GnRH ahead of starting chemotherapy so that you protect the follicles. If she is a married woman and she is still not having children, you can still go for embryo cryopreservation and then start treatment. If not, you should at least offer it and then put it on paper that these things are offered and the patient is not wanting after discussion, and then start whatever treatment you want. Otherwise, you can be taken legally responsible for spoiling her fertility. Okay, so this is once again a teaching for all the students here in YMO. When you have a very, very young patient sitting in front of you, before starting any chemotherapy, as a medical oncologist, onco fertility plays a very, very important role. So you have to go and ask for onco fertility options. Okay, fine, Biju. So let us say that all these were all fine. You told me something about opposite breast. I will do every year 6 months alternating MR mammogram. Is it for everybody?
no, sir. Actually, clinical examination every 3 months for the first 2 years, and then 6 months.
No. I'm asking you, for whom will you do MR mammogram?
So this patient would still be in her 20s to 30 years of age, for which mammogram will not be reliable. So I do an MR mammogram until 30 years of age.
Ultrasound.
So ultrasound is not the
fatty breast. Ultrasound is the investigation of choice. For whom are you going to do MR mammogram?
Sir, those patients who has a lifetime risk of more than 20% to develop a breast cancer, or the patient.
How will you decide somebody who has more than 20% life risk? What are you going? How are you going to screen this patient? And what are you going to screen in this patient? Okay, this patient comes to you after 7 years. Now has come with the ovarian tumor, and when you did a biopsy, she has come with multiple peritoneal deposits, and she is positive for papillary serous adenocarcinoma, high grade of the ovary. What do you think this patient is having?
This patient
8 years back treated for CA breast, now coming with CA ovary.
They may either have an BRCA or an ATM mutation or a P53 mutation.
So now the second medical oncologist is doing a germline BRCA, and germline BRCA 1 is positive. Could you have protected her?
Yes, sir. If she was,
what should you have done in the beginning when you treated the patient?
These patients, we should have done an extended germline mutation panel testing for BRCA.
If not extended, you should at least do BRCA screening.
Yes.
So any young patient, I know the family history is not there. From age old, you have the Gale model, the BRCA Pro model. They have so many models for screening for hereditary breast syndromes. But mere age of the patient is one of the conditions where you can take up. So if you are deciding to do a BRCA1-2 testing in this patient, what is the steps you should follow? Her mother comes and asks you, is it a familial tumor? So how are you going to test this patient?
So first we should find out if the female falls in a lifetime risk of breast cancer of more than 20%.
How will you find it out?
Either we can, you should use a model which uses the family history, either that the BRCA Pro model.
Models you are aware of, Biju?
So one is the Gale model, but the next one is the Claus et al. Model, and then we have the BRCA Pro, and then the TIREC model. Out of this BRCA Pro and TIREC has.
So which amongst the 4 of the models you told is validated in Indian population or at least Asian population?
Gale model. I'm not sure.
So you need a validated model to do all that, and practically speaking, this is difficult to tell now, right? So you have to go by your gut feeling. So let us say this is a very young girl and you want to prevent future malignancy. So what is the first step of screening a patient? What is the first step that you would want to follow?
So to do this,
You have to do genetic
germline
counseling.
mutation test, germline
You
counseling.
have to do genetic counseling.
Yes.
Then you have to get the written consent. Then you have to do germline screening. Then you should do a post-test counseling. Then you should try to offer what can be done for the patient. So this series you should tell properly. If in fact if Professor Kaleshelvi was there, she would have got very wild with you for telling I will do germline testing without talking about genetic counseling. So genetic counseling, pre-test counseling, testing, post-test counseling, and then you will take an action. Okay. So once again, you have missed to offer oncofertility. You have missed to offer her genetic counseling and screening. Given an 18-year-old with invasive ductal carcinoma in the breast, correct? If she was BRCA1 positive, what is the histotype you would have expected in the tumor, Biju?
Triple negatives. Usually they are triple negative.
Which is more common, BRCA1 or BRCA2?
BRCA1 is more common.
Suppose if this patient was a BRCA carrier, you got the consent from her and tested, how will your management change?
So you would offer her an option of bilateral mastectomy and selfing oophorectomy because
No, first in your treatment, you're still treating the patient.
treatment because
let us say this patient came as a triple negative breast cancer, BRCA1 carrier. What are you going to treat? What are you going to do?
So if she's triple negative and BRCA carrier, there is an option to give her adjuvant olaparib for a period of 1 year based upon the Olympia trial.
So based on the Olympia trial, you can offer her that. So that is for the treatment part. Now, what are you going to do for her as a carrier? So how will you approach this patient? She is a BRCA1 carrier. How will you approach this patient after treatment is over?
So prior to surgery, I will discuss the risk of her developing and subsequent breast cancer and other ovarian cancer. So I would give her the option of undergoing bilateral mastectomy with selfing or oophorectomy to reduce the risk of subsequent cancers. And now she's
by doing a bilateral, say, oophorectomy, how much of risk reduction are you doing on the contralateral breast? Suppose a patient says, I don't want to remove my other breast for cosmetic reason. If you want, you remove my ovary. At least it is not seen outside. So how much risk reduction to the breast you are doing by removing the ovary?
80%.
80. Sure.
30%.
Roughly 50%. Okay. Reduction in the risk of the contralateral breast cancer can be done. Accepted. Suppose you do a risk reduction mastectomy. You told me that now. By how much percentage are you decreasing? Still, can the patient get some breast-related tumor after removing the breast?
So up to 99% protection we get from bilateral
What is that
mastectomy.
1%? Why are you leaving back 1%?
That may be because of the microscopic metastasis which have already gone.
No. Where will the patient after skin sparing mastectomy, if at all they develop a breast tumor, where can they get it?
Axillary tail.
Yes. So there could be some breast tissue left in the axillary tail, and that can cause recurrence. Okay, by doing a BSO, risk reduction salpingo-oophorectomy, what percentage of patients will be protected against ovarian cancer?
Around 95%.
No, you're guessing. Okay, I will go to your percentage. Go back and read that. Where is that? Where have you left that 2% cancer now?
5% chance of primary peritoneal carcinomatosis.
Accepted. But where else can it come from? When you do a RRSO, what is left behind in the patient? Still the intramural part of the tube will be there inside the uterus. Okay, the fallopian tube, coelomic epithelium is still there. The fimbrial end and the ovary is being removed. There's a small part of the tube inside the uterus. From there, still there can be malignancy. That's that 1%. Okay. So RRSO and risk reduction mastectomy. So these are all prophylactic or preventive surgeries. Are there any preventive medications you can give these patients?
So for this patient, anyhow, we'll not be able to give chemo prevention. But for a patient who is not having a malignancy but harboring mutation, we can give chemo prevention with tamoxifen or raloxifene.
Why are you saying that? Why not for this patient?
Because she is hormone negative patient, we cannot give hormone therapy.
Okay, so what is the chance that the opposite breast will come hormone positive? Suppose she's a BRCA2 carrier, okay, what is the incidence of hormone negative or hormone positive? Which tumor, which BRCA gene normally is responsive to hormone and which produces hormone positive tumors?
BRCA2 pattern is almost like sporadic tumors, so it will be mostly hormone positive.
So you don't know what the other breast is going to get, and by giving tamoxifen, one breast you have already removed and attended, right? So your worry is about the opposite breast. So that is why you are going to give. So you can do surgical prevention, you can do chemo prevention, and then if these two you are not doing, you have to do active surveillance. And in those patients comes the question of doing 6 monthly mammogram, alternating between ultrasound and MRI every 6 months, so that you will be able to pick up higher sensitivity. So what happens is annual MRIs will be there, and that's a part of the guideline in BRCA carriers. So you have not even tested BRCA in your initial part of management of the patient, but later during follow-up, if you say I'm going to do regular MRIs, you may be erring. That is what I wanted to bring it up for discussion. Okay. So if this is all for the patient, the last question, because we are hitting 8:45 now, so this will be the last question. What did you when you have not told me anything about their family members? I told you she's a BRCA1 carrier.
Yes, sir.
What will you advise the family members?
So if she's a BRCA1 carrier, we have to give family counseling for her family members as well as advise genetic testing for her family members to at least the first.
What genetic tests will you do for their family members?
Whatever mutation profile she is having, we'll test for the specific mutation in their family members.
So she is the index case. So from her, once you get the exact variant that is prevalent, you can do a more targeted testing of the same mutation variant. The polymorphism can be checked in the siblings, so that if they are carriers, you can give them the option of risk prevention, risk reduction procedures as soon as fertility is done. So many things can be done for the family members so that you can prevent cancer in them. And if they have male members, you can send the male members for urology counseling, because the male members who are carriers, although the guidelines are not very clear, but ad hoc practice is if somebody is a carrier of BRCA mutation and in close first degree relatives, they have a higher risk of pancreatic, and also they may have the risk of prostate cancer, right? High grade PIN is possible. So you may have to send them for a urology counseling. If there is any calcification in the prostate, it may need to be evaluated, which otherwise you won't be evaluating, correct? The extended family should also be tested. Extended from the patient, you should test the family members if they are BRCA carriers. So you've done well, Biju. Just consolidate the idea. I will just give you 5 points of my observation, and then I will ask Satya, and we have Raja and other people here. I think I saw my friend Nikita come in and go out. I don't know if she's also there. So the thing is, you have to, if it's a young patient, keep the mind open. Look at pediatric malignancies like what Dr. Satya mentioned. Keep lymphoproliferative disorders in mind, keep RMS in mind, keep pediatric sarcomas in mind, and last come to CA breast. Although your case is a case of CA breast, number one. And once you have a young girl with CA breast, don't forget to think of two things. One is to take a detailed family history, screen for hereditary breast and breast and ovarian syndromes. And number two, don't forget to offer oncofertility preservation, either in the form of GnRH or in the form of cryopreservation of embryos. And when you're looking at future follow-up, you should be able to test the family members and also follow up this patient depending on whatever hereditary cancer they are having. Other things you have already nicely elucidated, whether there is history of radiation in the childhood and whether was having any other cancer, all those things you have told. Whatever high risk factors are there for the young woman, you have very nicely told. But don't forget these 2 points. Okay. Satya, sir, anything else from your end? Then we can go to the next case. Arumugam, sir, anything else from your end for Biju?
Hello, sir. Satya, are you online? One thing he told that late menopause, you have to, the age is 55. So
Okay, sir.
you have to tell, and you have to know the age limit of this precocious puberty. less than 8 years.
Okay,
So
sir.
it's early menarche and late menopause, you have to know.
Okay, sir.
Then other thing covered one. Okay. So with this other examiners exposure, you can just think how to we prepare.
Okay, sir.
Okay.
Okay, sir.
So can we move to the next case?
Yes, we'll move to the next case.
Thank you, sir.
Oh. Naveen is with you, Biju?
Yes, sir.
Yes, sir.
Yeah, okay. You can share the slides.
Actually, Naveen can just start presenting the case. It's a short case. So one-liner history and you can go for examination, Naveen.
Yes, sir. Am I audible, sir?
Yes, you are very well audible. You can give a one-liner history and directly go for, or the salient history and you go for examination because yours is a short case.
Okay, sir.
We have only about 20 minutes, so we'll quickly go for discussion.
So my case is a 17 years old boy. He presented with the complaint of swelling on the neck for last 2 months, which was gradually increasing the size. And he also gives the history of excision of the swelling 2 weeks back. And there was no history of fever, throat pain, difficulty in swelling or breathing difficulty. No history
Yeah,
of.
Naveen, so only positive history and salient negative history you can run through.
Okay, so
Can
he
you
did not.
summarize? Can you summarize? Can you go down the slides and summarize? What is your history? So in history,
In
it is
history,
a 2 month history of swelling. Where?
sir, in the neck region, he gives
Very
the
good.
neck region for the 2 months, and there is no other any symptoms. He presented only the
What
swelling of the
symptoms?
neck.
What are these constitutional symptoms that you are asking them? What is it? What are you trying to target this patient by
Actually,
asking
sir,
such questions?
as he presented with the neck swelling, so it will be, I will ask about the fever and any throat infections or any throat pain and other like the
No, you
weight
feel it
loss.
is malignancy or benign?
So
You can
first,
directly go to the point.
I'll consider the benign only.
Okay. For exam reason, I'll again tell you. Please, you have crossed your masters and now you are in super specialty training. You are in an onco center where examiners will come to you, or you may go to another center where examiners are going to come to that center. So for benign sore throat and cough and infectious mononucleosis lymph nodes, they won't keep that case for you. Okay, so let us assume it is cancer. So don't draw your own trap and jump into it. Okay. So 17-year-old boy, cervical lymphadenopathy, you are asking for history of fever. Why are you asking for the history of fever? What are you targeting by asking that question?
Sir, I want to know about the B symptoms of the
Please
lymphoproliferative.
define these symptoms, Naveen.
Sir, one is the fever, more than 38 degrees Celsius or 100.4 degree Fahrenheit. Then there is a drenching night sweat and weight
For
loss.
how many days? For months? For weeks? For years? Definition of B symptoms for fever. Over what duration? One episode which occurred 1 month back. Is it B symptom? Persistent, present over last 4 weeks, over 6 weeks, or 2 weeks. What is the duration of B symptoms?
Sir, at least for persistent rising temperature, at least for 3 days. So I'm not sure, sir. 1 week.
Okay, please proceed with the other B symptoms.
Another is the drenching night sweat and the weight loss more than 10% in last 6 months.
Okay. So, what is weight loss of how much? What do you call a significant weight loss?
So more than 10% of the body weight in the last 6 months, unintentional.
What was the B symptom which was always was present earlier and was later taken off?
Sir,
Suppose this patient came with B symptoms.
yes, sir.
What lymphoma are you suspecting? Hodgkin or non-Hodgkin?
So seeing the age, I'll consider the Hodgkin lymphoma only.
Okay, non-Hodgkin is not common in 17 years, Naveen.
Yes, sir, it
Which
is
age
there.
will you suspect non-Hodgkin?
Usually in the middle age group or the higher age group, above the 45, 50 years of the age.
Is what? Hodgkin or non-Hodgkin?
Non-Hodgkin.
Sure. Okay, please tell me. So you have a 17-year-old boy with some neck nodes.
Yes, sir.
Please go ahead with the examination. What did you find in examination? What all did you examine in this patient?
Sir, I examined the general examination I have done, including measuring the height, weight, and the vitals, performance status. He was the ECOG PS1 with the no pallor icterus and the cyanosis. Vitals were the normal. Then I underwent the local examination, neck examination. So on inspection, there was a small swelling present on the right lateral side of the neck at the level of hyoid bone, which becomes prominent on turning the head towards the left side, and there was no visible pulsation, no other swelling is prominent, and there is a small surgical scar present at submental region. On palpation, I confirmed the finding of inspection, and there is a multiple small bilateral lymph nodes palpable, a largest measuring at right level 2 into 2 centimeters, single, non-tender, mobile, firm in consistency, and another at left level 2, 1 into 1 centimeter, single, non-tender, mobile, firm in consistency, and overlying skin is normal. Then I included the other lymph node examination apart from the cervical examination, which was included in the neck examination. The same finding, and there is no axillary, epitrochial, inguinal, femoral, or popliteal groups of lymph node palpable. Oral cavity and oropharynx normal, no tonsil enlargement, nasal cavity normal, and systemic examination, cardiovascular system, respiratory system, per abdomen and the CNS were within normal limits, no hepatosplenomegaly, and the total examination, both tests is present and normal.
So can you tell me, so it's a 17-year-old boy with no B symptoms. So can you tell me the positive points of your examination?
So in the positive point, there was only neck node, bilateral neck node was palpable. Largest measuring 2 into 2 centimeter at right level 2 station and 1 into 1 centimeter at level 2 station. And there is a one surgical scar at the submental region.
So everything is in right side or you have bilateral neck nodes?
Bilaterals. Right
so
side
you have
is...
a 17-year-old with bilateral neck nodes.
Yes, sir.
So in which system do you think is involved in this cancer? Assuming it is cancer. Do you think is a disorder?
System. Lymphoreticular system. A lymphoreticular system.
So you feel it's a lymphoproliferative disorder?
Lymphoproliferative system.
Okay, so what lymphoproliferative disorder you want? So if you're thinking of a lymphoproliferative disorder, Naveen, can you tell me head to toe what all you will examine in a lymphoproliferative disorder?
Sir, I'll apart from the general examination,
what all constitutes as lymphoproliferative disorder in a patient? At least at clinical DDs, what all are you going to consider? This patient, your junior resident from the casualty is telling, sir, there is a patient, 17-year-old boy, he has some small neck nodes, he has come with fever. Like I'm giving you the history. He has come with fever, he has come to the casualty, he looks a little tired. So in clinical examination, you are saying this could be a lymphoproliferative disorder. So head to toe, what are the things you will ask your junior to examine?
Sir, first I will examine all the groups of the lymph node, starting from the preauricular occipital lymph node.
Generalized lymphadenopathy, you will ask next. Ask him to examine. What else?
We'll ask for the presence of any liver hepatomegaly and splenomegaly, liver and spleen I'll palpate.
He's got a small tender hepatomegaly and a small spleen, 3 centimeter. And he's got small nodes in the axilla and also in the inguinal region. So are you convinced it can definitely be a lymphoproliferative disorder?
No, sir.
No. Why not? He's got nodes in the neck, he's got nodes in the axilla, he's got small inguinal nodes, he has got hepatosplenomegaly.
Yes, sir.
So you are not convinced it's a lymphoproliferative disorder.
Sir, I convinced with the lymphoproliferative.
So if you are saying it's an LPD, what we write in the case sheet, lymphoproliferative disorder, what are the DDs under the lymphoproliferative disorder you want to consider in a 17-year-old is my question.
The first will be the leukemia and the lymphoma only.
Very good. So what leukemia do you think will come present like this?
The ALL and AML will be common in this age group.
Very good. So between ALL and AML, which one is more common with the presentation I have given you?
ALL.
If I say it is AML, which AML will come with lymphadenopathy and hepatosplenomegaly?
AML also present with the lymphadenopathy, but it is less common than the.
Accepted. That's why you said it is ALL. But I am telling you this is AML. Which AML will come with hepatosplenomegaly and lymphadenopathy? What variant of AML?
M2 or M2?
Variant. No, not M2. M4, M5, monocytic, myelomonocytic, and monocytic variants can have organ infiltration. So, if it is ALL, can you tell me from head to toe what all you will examine?
All the lymph node groups and then the oral cavity for the tonsillar region and then.
Did you examine the fundus, Naveen? And what is the importance of fundus examination in a lymphoproliferative disorder?
If there is any CNS infiltration of the tumor, then there will be the rise in the ICT, intracranial pressure, and that gives the on fundal examination. There will be the
CNS involvement, raised ICP accepted. What else can be seen in the fundus in a leukemic patient?
Apart from the papilledema only, sir, because of the raised ICT.
You can look for leukemic infiltration of the fundus. You will have a lot of, exudates that can be seen with very high count. There can be leukemic fundus. Leukemic fundus itself is a very typical finding. You will have a lot of hemorrhages, flame-shaped hemorrhages in the retina because of low platelet count. In addition to that, CNS involvement, you may have papilledema. So from when you say from head to toe, you have to look for pallor. As you come down in the eye, you can look for subconjunctival hemorrhages and then you will look for the fundus. As you go down, nose, you look for nasal twang of speech. Why do you look for nasal twang of speech in the case of lymphoproliferative disorder?
Maybe the.
Can there be an epithelial tumor in this age which will present with the finding you have told in your case with bilateral neck nodes?
Yes, the carcinoma, like the nasopharyngeal carcinoma, may be present.
Very good. So, what will be the first symptom of nasopharyngeal carcinoma?
Nasal blockage or.
So, nasal blockage, sometimes nasal discharge,
Yes.
eustachian catarrh, difficulty in breathing, the nasal speech and all that can be there in naso. That you should see in a lymphoproliferative disorder. Okay, where you have also nasopharynx, involvement of the Walde's ring can cause alterations in the breathing, and there can be. And what do you see in the oral cavity? Look for tonsils. Look for hemorrhages. Where will you look for hemorrhages in the oral cavity?
Soft.
Very good. Soft palate.
Soft palate.
Okay, so you can look for hemorrhages in the oral cavity. You can look for oral thrush. You can look for gum bleed. Acute leukemias can have gum bleed and poor oral hygiene. Right?
Yes,
and then you come to the neck. You already have examined and told me the neck findings. As you examine the neck, you have to look for the axilla, you have to look for the inguinal, you have to look at all other regions. What specific lymph node examination will tell you that this is likely to be non-Hodgkin and not Hodgkin lymphoma? I found this dash nodes, so it is likely to be NHL. What are those nodes at dash sites? Fill in the blanks.
So if there is a peripheral nodes like the epitracheal nodes, presence of the epitracheal nodes.
Popliteal nodes, epitrochlear nodes, these all will tell you that it is likely to be non-Hodgkin lymphoma. So by clinical examination, if you want to pin down between Hodgkin and non-Hodgkin, what will tell you one can be Hodgkin, what can tell you one is non-Hodgkin other than the peripheral nodal involvement?
In Hodgkin's lymphoma, usually the lymph node location in the axial region, and non-Hodgkin's lymphoma in the peripheral region. Another is in Hodgkin's lymphoma, there is a contiguous involvement of the lymph nodes, but in the non-Hodgkin's lymphoma, it will be the aggregated. Then
And you can have extranodal involvement, more common with
the non-Hodgkin's lymphoma.
Excellent. Please define what is significant lymphadenopathy.
So significant lymphadenopathy, it is considered more than 1 centimeter in all the regions except for the inguinal region, where it is more than 1.5 centimeter, and in supraclavicular region it is more than 0.5 centimeter is also considered significant.
Okay, 1.5 to 2 centimeters, sometime in the inguinal region. So if you have the same patient with a 2 centimeter node in bilateral inguinal region, and if you have the same patient with a level 3 1 centimeter node, you want to do IHC and all the molecular tests, where will you go and take the lymphadenopathy biopsy?
I'll prefer in the cervical region.
Very good. Okay, so you will prefer in the cervical region. If a patient has mediastinal nodes, what other clinical finding will you look for in this patient who has come with a short history of 2 months?
Maybe the complaint of the external breathing difficulties.
Why should there be breathing difficulty because of mediastinal involvement?
Because of the compression of the other structures.
So, say features of SVCO, no?
Yes, sir.
Puffiness of face,
Puffiness of face.
difficulty in breathing, puffiness of face, dilated veins over the chest. So these things you have missed in general examination. So see, keeping a lymph node case is a very simple case. It's basically MD case. Okay, there we'll be discussing tuberculosis, sarcoidosis, so many other things. Allergic lymphadenopathy, drug-induced lymphadenopathy, pseudo-lymphoma, all those discussions will come. Now for you, when there's a lymphadenopathy, we would like to give you 3-4 differential diagnoses to ask what all you have examined in the short case, because you're not going to ask history. So this can be anything, starting from lymphoma to epithelial tumors to even metastasis in the lymph nodes, right? So we want to know what all you have examined. So if you're looking, you only told me it is a lymphoproliferative disorder. So head to toe examination should be complete. Starting from pallor to icterus to cyanosis may not be so significant. What are all the groups of lymph nodes that are involved, and is there any pedal edema? Why should there be pedal edema in this patient? What's the importance of finding pedal edema in this patient?
Pedal edema, one is because of the hypoalbuminemia and hypoalbuminemia, one reason.
Accepted. What else?
Other things maybe the because of the para-aortic lymph nodes and all. There is a para-aortic and inguinal lymph nodes compression, then there may be the
There involvement of abdominal retroperitoneal lymph nodes, and you should also rule out DVT. Yes. So whether there is any pedal edema or if there is any lower limb edema, unilateral or bilateral, because of mass effect itself, it can be there, or it can be because of the presence of deep vein thrombosis. So in a lymphadenopathy patient, you have to do head-to-toe examination, including fundus. I'm quite sure most of you don't carry ophthalmoscope, you would have missed fundus examination. I don't know how serious examiners will normally take, but there can be some people who will penalize you for not looking at the fundus. And of course, somebody has mentioned, I think Armugam has mentioned testis. You have mentioned in your clinical examination testis. If you miss scrotal examination and testis, again, they will be very upset. So you have to do a head-to-toe examination. So now coming back to your patient, bilateral neck nodes and no other nodes. What's your differential diagnosis?
The first lymphoproliferative disorders, and among the lymphoproliferative disorders, Hodgkin's lymphoma will be the first diagnosis.
So did you do a biopsy? What do you want to do for this patient? You want to do an FNAC or a biopsy?
Sir, biopsy. I will prefer the biopsy.
What was the biopsy report?
The biopsy reports microscopy shows lymph nodes with the complete effacement of the architecture and the showing seeds of lymphocytes admixed with the several mononuclear, binucleate, and multinucleated large atypical cells having prominent nuclei. Several thick wall hyalinized blood vessels seen, mitosis seen. Focal area shows pericapsular. fat infiltration impression features are suspicious of lymphoma.
So morphologically, what do you think this is?
So morphically, because there is a complete effacement of the architecture and there is a showing seeds of the lymphocytes, so it will be the showing the feature of the B cell lymphoma. Other yes, a B cell lymphoma.
The effacement of the architecture, complete effacement with sheets of lymphocytes actually goes more in favor of NHL.
NHL.
Instead of finding an effacement, if you have polymorphous infiltrate of mononuclear epithelioid and multiple inflammatory cells, it goes in favor of Hodgkin. But here, what is that one point which you can see and tell this is likely to be this lymphoma? What is seen? Do you find Hodgkin cells being described here?
No, sir, Hodgkin cells is not described here.
Sure. What are those several mononuclear or binucleate, multinucleate large atypical cells with prominent nucleus?
So these are the atypical cells only because they have not mentioned only there is a one prominent nuclei they have mentioning. So I'm not sure whether this is a complete description of Hodgkin cells or not.
Okay, so now what do you want to do for this patient?
I'll go for the immunohistochemistry for the confirmation.
Can you please tell me how will you proceed with the immunohistochemistry algorithm for a lymphoproliferative disorder?
I'll ask for the sir all the T cell and the B cell markers, including the CD3, CD5, CD20, CD45, CD15,
We will
30.
go one by one. What is, let us say your pathologist tells me I can't waste money. Tell me one by one. As you tell, I will put tell positive or negative. So what is the first one that you will put for in any patient with suspected lymphoproliferative disorder?
CD45.
What does CD45 tell you?
The CD45 will tell that whether it is the lymphoma or not. Means the B cell lymphoma is not.
So LCA, CD45, you will want to say that whether it's lymphoma or not. Here CD45 is negative. Now what do you want? Cytokeratin is also negative. What do you want to do? Okay, we will go your way. CD45 is positive. What do you want to do? Tell me the next what you want. I will immediately tell. So what's your what is your clinical diagnosis for this patient? You said you are suspecting lymphoma.
Yes,
Hodgkin
sir.
or non-Hodgkin?
Hodgkin, sir. I'll ask for the CD15 and 30. After the 45 is negative, the next marker will be the CD15 and 30. If I have to select only two.
So that you are going in lines of Hodgkin lymphoma.
Yes.
Fine. So here CD30 is positive in the large mononuclear and binucleate atypical cells. CD20 is negative. What's your diagnosis?
Sir, classical Hodgkin's lymphoma. If CD45, CD20 negative, CD30 positive, classical Hodgkin's lymphoma.
So you are saved. Suppose you went and sent this patient for doing the lymph node biopsy from the neck. Your surgeon calls back saying that wherever I put the knife, he was continuously bleeding. I could not stop the bleeding. Your patient is in ICU. Platelet count is 8,000. What's your diagnosis? So
then it will be
the patient may be looking cold. Don't see again. I'm telling you. You please do whatever you're doing in your OP at TVMCH. If this patient came to you to the OP, as soon as you examine the patient and put query lymphoma, what are the first tests that you will send for the patient?
PVC.
You didn't tell me. You said I will go for an exception biopsy of the lymph node, right?
Yes, sir. Sir,
See, that is what I'm telling you. You may be biased. You may be knowing this is a case of lymphoma. In the exam, you will go and say, I will do a biopsy. Basic things first. The lymphoproliferative disorder, after head-to-toe examination, what will you do first? I will look at the CBC. If the counts are high, I will look for tumor lysis. I will look for LDH. If all these are normal, I will finish off the biochemical profile to rule out tumor lysis. I will do coagulation profile and viral markers,
Yes.
HIV, HPSAG, and anti-HCV. Once I find that all this is normal, I will refer to the surgeon for an excision biopsy of the lymph node. Please go in the order like what you do in your OP. Don't do the mistake of jumping when you're doing a case presentation. Okay?
Yes, sir.
Okay, now this has come as Hodgkin lymphoma. So what do you want to do next? Classic Hodgkin lymphoma. What next?
So then I'll ask for the radiological investigation, preferably the
Okay,
PET CT.
just tell me what test. Don't need to explain. What do you want to do?
The next, I'll ask for the PET CT. PET CT whole
PET
body.
CT.
Yes.
Okay. So PET CT has shown bilateral neck nodes, few mediastinal nodes, infradiaphragmatic, no nodes are there. What's your stage?
Stage 2A.
You want to do IPSS scoring? What is IPSS score?
So IPSS score is basically for the stage 3 and stage 4. That
Very
includes
good. So IPSS is for advanced stage Hodgkin. Okay. I will say this patient is having infradiaphragmatic and supradiaphragmatic nodes in the mediastinum, and what you got was mainly the neck nodes. What next? Hodgkin lymphoma classic.
Well, after PET CT, then it will be the stage 3 only.
Stage 3A.
Stage 3A.
What next? Bone marrow, yes or no?
Sir, if the PET CT is now, sir, bone marrow is not recommended. Only bone marrow is not recommended at present.
Sure.
Yes, sir.
So you can skip. Suppose this came as DLBCL. Will you do bone marrow or not?
Yes, sir. In that cases, if the PET is negative, then we can we'll go for the bone marrow.
So if unequivocally PET is positive in either Hodgkin or non-Hodgkin, you can skip. In Hodgkin lymphoma up to 2A, you can skip. If B symptoms are there or stage 3 is there, it is still optional. It's an institutional practice. You can say in our institution, we are not doing. What is the difference in the PET uptake if it was a Hodgkin? And what is the difference in the PET uptake if it is a non-Hodgkin when it comes to bone marrow involvement? How will the bone marrow look in NHL? How will the bone marrow involvement look in HL?
Sir, in HL, in non-Hodgkin's lymphoma, there will be the diffuse uptake of the bone marrow because of the cytokine release. But in Hodgkin's lymphoma, usually it does not show the.
How will it look, bone marrow involvement in Hodgkin lymphoma? Patchy or diffuse?
Very patchy only.
Usually you have patchy uptake, but once again, so that's an institutional difference. You can go into a controversy with the examiner, whether you say you want or you don't want. So see the pulse of the examiner and you answer. So this is a stage 3A Hodgkin lymphoma, IPSS score 3. What do you want to do? I will say IPSS 4 no. What do you want to do? What do you do in your institution? You tell.
So we'll plan the treatment, and before the plan of the treatment, since the child is young, 17 years, so we'll counsel about the infertility issue and advise for the semen analysis and the sperm banking possible.
So what's your treatment plan? Tell me the chemotherapy plan now.
So we'll go for the ABVD regimen with the 2 cycles, and then we'll ask for the PET CT, interim PET CT.
IPET is fuel 3/5 in all sites.
Then we the village score is 3, so we'll go for the AVD regimen, 4 cycles more.
3/5 is metabolic CR or not?
Yes, sir, metabolic C. Interim PT, there is, so it is considered as a metabolic, it is complete response only, but since it is the interim PET CT, so maybe it is less likely to convert into the complete response on the end of the treatment.
No. My question is interim PET 3/5 dual score CR or not?
CR.
So what do you want to do further?
Then we'll continue the chemotherapy, avoiding the bleomycin AVD regimen for the 4 more cycles.
When you did the PET CT in interim PET, incidentally, your PET CT, your patient called back saying that patient is having dual 3 at one site and all the rest is dual 1, but patient has multiple patchy uptake in both lungs. I don't know whether it is infection. And then the patient comes back saying that he has got cough and something like a viral pneumonitis. He has
because,
ascites.
So because we have given the bleomycin, so I will suspect the bleomycin toxicity.
What are the risk factors for bleomycin toxicity?
So, presence of the recent viral infections, then
other than that, for whom will you want to avoid bleomycin?
the old age.
Then
Old age and chronic smokers.
Then underlying lung infection, like COPD. Then how is bleomycin excreted and what is one risk factor for bleomycin toxicity? Renal failure. Old age, smoker, renal failure and pre-existing lung conditions. Do you routinely do how do you make fitness for bleomycin in all patients? What is the investigation you want to do?
Sir, in our institute, we do the pulmonary function test only. But
you didn't tell me. You didn't tell me CBC. You didn't tell me coagulation profile. You didn't tell me viral markers. Before planning ABVD, you didn't tell me about doing PFT. You told me about sperm banking. What's the risk of infertility with ABVD?
Sir, percentage I'm not sure, but it is less only.
If this patient was on BFCOP, your next bed patient is on ABVD, who will get infertility?
In BCOP regimen.
ABVD, the incidence of infertility is very less.
Yes.
All the 4 drugs. Okay. So yes, technically speaking, it is less, but you are very right that you have to offer sperm banking in all these patients. So yes, at the end of 6 cycles, the previous sites which were 3 are 3 and there is 2 sites which are actually dual 4. What do you want to do? Or I will say continues to be dual 3 after completing 6 cycles. Neck nodes have disappeared. Axilla, there are 2 nodes. These 2 nodes are still dual 3. Mediastinal and abdominal nodes are dual 3. 6 cycles AVD over. What do you want to do?
Sir, dual 3 will be considered as a PET CT negative PET CT only. So
end of treatment. You have one patient dual 3 interim PET. You have patient number 2 dual 3 end of treatment PET. Both are CR.
Yes, sir. Both are CR.
Sure. Please go back and read. D3 is not CR in end of treatment PET. In up to interim, it can be taken. End of treatment tells you there is persistent disease. Okay, if you are suspecting persistent disease, what do you want to do for the patient? It's a stage 3. All over you have para-aortic, but none of them are bulky, but you have few neck nodes, axial nodes, mediastinal nodes, para-aortic node, and all are dual 3. What would you like to do?
We will go for the end of the treatment persistent, it will go for the rebiopsy only.
What are you going to look for in rebiopsy? You are correct.
Sir, is there any transformation into the other types of the lymphoma?
What transformation can you expect in Hodgkin lymphoma? What is the transformation called?
The richest transformation? No.
Is it common in Hodgkin lymphoma?
No, sir.
I am setting a trap and you are jumping into it. No, and sir, some of your friends are also jumping into it in the chat box. In which lymphoma do you have Richter transformation?
The follicular lymphoma.
More common with
CLL.
CLL can go into DLBCL, right?
Yes.
Some of the indolent lymphomas may turn into aggressive type. That's fine. Hodgkin, do you get that?
No, sir. Usually we do not get.
You did a biopsy and I now found a DLBCL in that. What do you call it? What is mixed lymphoma? What is composite lymphoma? Go back and read, Naveen. Okay. What is composite lymphoma? What is mixed lymphoma? Sometimes you have two clones of cells causing two different diseases in the same patient. One causes in two different groups of nodes, one causes in the same node itself. So which is composite, which is mixed. So you may have another NHL component sitting in and your ABBD is not good enough to treat it. So the non-Hodgkin component may be persisting after 6 cycles. That is one possibility. Or else you may have Hodgkin itself that is resistant to your treatment. How do you define Hodgkin relapse, Naveen? So we are nearing 9:30. So last 2-3 questions. Define Hodgkin lymphoma relapse.
So relapse after completion of the first line chemotherapy, that is a PET negative within the 3 months of the completion of the treatment, and then if the patient presented with the disease, then it will be called as a relapse.
Accepted. Please classify Hodgkin lymphoma relapse.
The early relapse and the late relapse within the 1 year of the completion of the treatment will be called as the early relapse. And
what is primary progressive Hodgkin lymphoma?
The primary progressive Hodgkin's lymphoma, there will be no complete response at the end of the treatment.
What is primary? Okay, this patient went into dual score 1/5 at the end of treatment. 2.5 months after completion of treatment, patient comes with a new node. Biopsy is Hodgkin lymphoma. He was CR at the end of treatment. 2.5 months. This is case 1. How do you define this relapse? You have one patient who has relapsed 8 months after completion of treatment with CR. Now Hodgkin lymphoma. What do you call that patient? You have one patient who has come 2.5 years after treatment of Hodgkin lymphoma, rebiopsy done, Hodgkin lymphoma, relapse. What do you call that Hodgkin lymphoma?
The first case will be the primary progressive Hodgkin's lymphoma. The second case will be the early relapse, and the third case will be the late relapse Hodgkin's lymphoma.
So, what if suppose this patient has come with the primary relapse, primary progressive, very short DFS?
Yes,
patient has come to you with and says, I want to somehow get cured. So what are the treatment options you will give for this patient? What do you think is what are the molecular mechanisms why these patients are not responding? Normally Hodgkin responds well or not? You would have treated many patients by now. They usually respond well. So if a patient is going to progress like this on ABBD treatment, there is resistance to treatment. What do you think is the reason? And what is the salvage strategy you are going to take for these patients?
The salvage strategy, I will choose because the cure rate will be by the transplant. So I will choose the regimen which will favor the.
What regimen do you want to give for this patient to salvage?
Sir, all the regimens is almost equally effective, but we will prefer the GVD regimen.
So you can give GVD, you can give ICE, you can give DAP, you can give any of these. So as of now, per guideline, you have common salvage regimens irrespective of the type of relapse. But let us say this is a doctor and he says, please do me the best because I think I have a resistant Hodgkin. What else can be incorporated into these patients before taking them up for transplant, which will enhance? There are trials which are going on. What's the role of IO? What is the role of brentuximab vedotin? You don't want to use any of the brentuximab based salvage?
Brentuximab based always also, sir, it is used. Brentuximab plus nivolumab or brentuximab with the chemotherapy.
What do you think is a PDL1 expression in lymphoma, Hodgkin lymphoma? Do you want to check a PDL1 before exposing them to pembrolizumab or limonlimab?
Sir, ideally it should be, but since in Hodgkin's lymphoma, PDL expression is in quite high incidence, so
ideally it is not done. because you know anyway your patients, which is the other lymphoma which has a very high expression of PDL1. That's why they are quite aggressive, but they are very curable also. Which is the other non-Hodgkin lymphoma which has very high PDL1 expression? PMBCL. PMBCL, primary mediastinal B-cell lymphoma. Okay.
Yes, sir.
So these are the patients. Suppose this patient was a very old patient. Okay, this is a very old patient. The last question. The 70-year-old male coming with a creatinine of 2.2 is a CKD patient, otherwise PS1. ECOG status PS1. What regimen you want to choose? He's a smoker. Any data is there?
The brentuximab vedotin plus dacarbazine we can use, or single agent brentuximab vedotin we can use.
No, patient is PS1 otherwise 70 years, except that he's a CKD. What are the two regimens? What do you want to avoid in this patient?
The bleomycin we can avoid. We have to avoid
So to substitute bleomycin, what else can you use?
brentuximab vedotin.
What is that regimen called?
BR-ABD regimen.
AAVD, right?
Yeah.
AAVD regimen,
Yeah.
where you're using brentuximab vedotin in the place of bleomycin.
Yes.
What is the other one where it has not yet come up in the guidelines? Last ASH they presented the paper. What else can be used? It has been checked for patients starting beyond 18 years.
Sorry, sir.
Beyond 18 years up to adults, they have checked another regimen, bleomycin sparing regimen, which the graph goes up. Last ASH itself, the paper was presented and it's coming into guidelines and can be considered is already there up in many guidelines. Instead of bleomycin in older people. What's the role of nivolumab? Can you give nivolumab in the upfront setting?
Nivolumab ABD regimen also it is.
NABD. So AABD, NABD, these are all options which can be given as a bleomycin sparing
Yes, sir.
for patients. Okay, so these are where you want to really try to avoid bleomycin, but you want to get better response rates for curative approaches. So these patients with primary Hodgkin generally tend to do bad. Your DAP and ICE may not salvage. So you can try to talk to the patient and then tell them that adding an upfront Nivo may probably cause better salvage. And once Nivo, you take the patient for Nivo and they go into CR, you can go for autologous transplant. Post autologous, if somebody fails, what is the treatment option? Is there any role of CAR-T therapy in Hodgkin lymphoma?
Yes, sir. CAR-T cell therapy is there, but we can after the
CAR-T is there in Hodgkin lymphoma. CAR-T, as of now, which target does CAR-T therapy target?
CD19.
Which target on the tumor?
CD19.
CD19. So is CD19 expressed by the Hodgkin cells?
No, sir.
So for Hodgkin, you don't have CAR-T. CAR-T is a salvage therapy for what type of lymphoma?
B-cell lymphoma.
Usually it is tried for DL